Hi everyone, Ravi here from the Two Lost Souls podcast. Before today's episode kicks off, I just wanted to share something with you that can make your sessions smoother, clearer, and way easier to run. It's called the TLS Agenda Timer, and it's available on Google Play or as a web app at timer.twolostsouls.co.uk. If you've ever struggled to keep an eye on the clock or wished you or your client could see how session time will be used as you set your agenda, or if you're working remotely and you're tired of juggling whiteboards and blurred backgrounds, this tool is a game changer. TLS Agenda Timer helps you structure sessions visually using blocks, and with TLS Agenda Timer Pro, you also get notes exports to speed up your admin, a ready-made library of CBT agenda items, and your own reusable templates. Give it a go at timer.twolostsouls.co.uk or get it from Google Play by searching TLS Agenda Timer. Good morning, good afternoon, and good evening, wherever and whenever you are listening. This is an episode of the Two Lost Souls podcast, all about ACT. My name is Ravi Amrith, and today, sadly, I'm still on my own in the therapy room to start with. Shell is away for another episode. You might be thinking, what, Ravi? Was it something you said? I don't think so. For our last scheduled episode, Shell was away having a spa day, if I remember correctly, and now sadly she is ill. So that's clearly proof that masks and squeezes spread diseases. Feel free to throw that rhyme in with any health anxiety clients that you're working with. I'm sure they'll love it. However, we are hoping that she gets well very soon and will join us for the next episode. That being said, that allows us to keep things nice and short for this intro. As usual, please visit our website at twolostsouls.co.uk. We have a whole host of resources and materials that we've linked to on there that are useful for the training journey and beyond. And please sign up to the Two Lost Souls mailing list, where you will find out about episodes before anyone else and also hear about some exciting projects that we're working on. So we have the pleasure of being joined in the therapy room today by Dr. Rich Bennett, who is a clinical psychologist and the clinical lead on the University of Birmingham high-intensity CBT course. Rich, how are you doing today?
I'm very well, thank you. It's an absolute pleasure to be here.
Thank you very much. Well, thank you for coming along. We're going to be covering a topic today that is quite well requested amongst the trainee community, and I think we'll get into why that is perhaps later on. Generally, we tend to start the show by asking people about how they got into CBT. I suppose sometimes the helping professions in general.
I worked in the NHS for about 25 years, and initially I worked as an occupational therapist. Like back in the 80s, I went to university, right? Because I'm that old. That was in the days where you sort of just went to uni without really having much of a plan, because you could, because people would give you a grant to do it that you didn't have to pay back. So I did psychology, and I didn't really know what I wanted to do with my life. But so I ended up training as an occupational therapist, partly because my brother has got a disability, and I met an occupational therapist through him. So I kind of owe everything to him, really. He won't be listening, but Chris, just in case you are, he's brilliant, right? And so he's very much... He sowed the seed in me, I think, of like wanting to be helpful. I suppose wanting to having a value of being helpful to other people. And so I was probably always going to end up in some kind of helping profession. And so I ended up in OT, realised after a while that wasn't quite for me. I could tell you a very funny story about a long-handled shoehorn, but it's after the watershed story. And I made the switch into clinical psychology a bit later. 2000, I started my clinical psychology training, so that's 25 years ago. But prior to that, I'd done some CBT training, which I think is interesting historically, just because, like, it was back in the 1900s. Like I was training at a time when a lot of the models that I now teach about hadn't been written.
Yeah,
and so my experience of being trained how to do formulation, for example, was just like, here's a blank piece of paper. I knew some stuff about thoughts and behaviors and emotions, and I knew about maintenance cycles and all of that kind of stuff. But it was like, armed with that knowledge, here's a blank piece of paper, sit down with the client and figure it out. So it was a much more transdiagnostic approach than I think people would be used to on the high intensity training nowadays, which partly by historical accident is just very influenced by Beckian cognitive therapy and the Oxford Cognitive Therapy Centre. That's just the model that the government adopted because when they decided to set up the IAPT as it was then, who did they ask? Of course they asked the OCTC, and they were very influenced by Beck. So that's kind of what we've got in the UK. But it's not the same the world over. So I started off being more interested in the transdiagnostic ways of working. During my psychology training, I had the great fortune of being able to do a primary certificate in rational emotive behaviour therapy, which is the original form of CBT, if people don't know that. So that's Albert Ellis back in the 1950s. My original training sowed the seed, and then REBT just landed in that fertile soil, like a much more transdiagnostic way of looking at the world. So I was then primed, I think, to accept all of the stuff that Steve Hayes was talking about, because that felt like, to me, it felt like more as like a descendant of REBT, a much more transdiagnostic way of looking at things. I think the bits I took from it were the importance of acceptance, which, again, I think, anyone who knows anything about REBT, like, acceptance was at the very heart of CBT at the start. So the idea that we would all be better off if we could accept reality rather than rail against it. One of the realities being that for most of us, we have a mind that just throws uncomfortable thoughts at us at a quite frightening rate often. I don't know what your mind is like, but my mind is like a sort of drunk Scotsman just hurling abuse at me for most of the time. And so I think my experience of trying to do thought challenging had often been that, like, clients intellectually get this. It doesn't stop it. They understand, like, I'd be better off if I didn't think the things I think. And I've got some tools now to question my mind when it does this, but it does still keep doing it. And so that's where I started, I think. That was the kind of part, in amongst the sort of 30% of what I understood of what he said in that first lecture that I went to. That bit really stuck because it sort of resonated with my REBT training. And then the other thing was values. So this idea of values, which I don't think I'd really come across in my therapy training. So this is, doing OT training, doing CBT training, then doing clinical psychology training. I don't think anyone had ever really talked to me about values, or the idea that what if we sat down with a client and talked to them about, what lights their candle? What do they care about? Rather than just seeing them as someone who's got some kind of a problem. Like, who are they outside of that? What internal drives kind of motivate who they want to be in the world, what they want to stand for, what kind of challenges they want to pick. So the idea of values, I think, and talking to people about that was the thing. That's the point where I really started, I suppose. I did my regular CBT practice, but I sprinkled some values seasoning on it. And so I gradually made a transition from being a more traditional kind of second wave CBT guy into a more third wave CBT guy. And I started with values, quickly followed up by, I guess, rediscovering my passion for acceptance. Like, what if these thoughts that you have, they are just part of the deal, right? They are just what we would expect to happen given your life experience. And what if they're not symptoms, in the way that most CBT formulations position them? They're just kind of normal phenomena, and you don't have to fight them or challenge them or change them to live a kind of meaningful life. What if you could be willing to sit with them, be willing to let your thoughts do what they want whilst you pursue the things in life that are meaningful to you? So that's how I made the transition, I think. Sprinkled a bit of values, then acceptance, and then kind of jumped ship.
Particularly when you were speaking about thought challenging there, because I suppose I see it a lot in day-to-day practice, in terms of if I'm in a dialogue with a client and I'm thought challenging their gaddy thoughts, for example, am I not just replaying the same process but just outside of their head? Are we not just engaging in the same maintenance cycle but just out in the open? And if we're doing exactly the same thing, where's that really getting us? And the fight adds quite a lot of stress in terms of people fighting against their own thoughts. So I can see that being quite an alluring way of immediately, I guess, removing some of that stress and distress that accompanies a lot of what people go through. And you spoke there about acceptance and values. For people who are new to ACT, what else would you say sets it apart from second wave CBTs and also other third wave approaches as well?
How long have you got? I suppose one of the big points of departure between ACT and, let's say, Beckian cognitive therapy, I should probably say, just to preface this, like when I'm talking about CBT, I would be talking about that as an umbrella term. Like CBT is not a unitary thing. It is a psychotherapeutic tradition within which there are different schools of thought. It's kind of like fruit, right? There's lots of different types of fruit. There's lots of different types of CBT. So if I say CBT, I'm referring to the overall umbrella, within which there's cognitive therapy, there's ACT, there's DBT, there's BA, there's a whole bunch of different things. I've forgotten the question now. So this happens with me. We'll get,
that's all right. Don't worry.
I was a sidebar conversation and I'll just forget the original question.
I was marveling at that metaphor because I think in the last bonus episode that we put out, I used some metaphor about CBT being ice cream, because you've got all the different types of ice cream and then all the different flavors of each one within the subtypes, and everyone's got their own preferred flavor, and not everyone serves the flavor that you like. I suppose the original question, though, was around what sets ACT apart from the second wave CBTs and other third wave approaches.
So what I was going to say was, I think in terms of the approach that Beckian cognitive therapy has taken, which has very much influenced the way CBT is delivered in the UK, is that they got on board with the medical model in the sense of, let's develop a different type of formulation and approach for various different so-called disorders. I know it doesn't work very well on the radio, but just imagine I'm doing like finger quotes, right, every time I say disorder, because ACT, I think it gets on board with the medical model for, research and pragmatic reasons, but philosophically, it does not see the occurrence of phenomena like emotions and thoughts as being indicative of an illness. It sees them as being just natural phenomena. If I were to put it to you like this, Mary had a little
lamb.
1, 2, 3, 4.
5.
Every time you think someone's going to judge you, you feel
scared.
Right. Congratulations, right? Your mind is just working as it should, right? Welcome to the human race. There's nothing wrong with you, right? That's just a normal response. That's your mind responding in the way that it has been taught to respond to certain stimuli. So whenever you hear Mary had a little, you think lamb. Whenever you hear 1, 2, 3, 4, you think 5. And whenever you feel like someone is going to judge you, you feel scared. That's based on your learning history. Now, so ACT would kind of see that as being, that's just normal, right? There's nothing wrong with you there. Maybe I'm a little bit more hardcore than most, but I don't even think that medicine is the right frame of reference to deal with distress. I mean, you take somebody with a diagnosis of OCD, like what's medically wrong with them?
Well, again, their brain is just braining. It's just following patterns as our brain is primed to do by taking in stimuli and having us engage in a particular behaviour to give us some reassurance and feel nice and fuzzy and warm by doing something to lessen the distress that we feel.
Right. I mean, yeah, agreed. Right. That, you couldn't give them a blood test and find out they've got OCD. People experience uncomfortable thoughts in the context of going about their life. Life is challenging and stressful. So people experience discomfort in the form of, thoughts and feelings. And the fact that they do doesn't really say anything about their medical state to me. I'm not particularly into versions of CBT that want to medicalize everything. And I'm not like, I'm not an activist or anything. I'm not going to set the place on fire. Because I get it. I understand that, the medical model and psychiatry is an attempt to make sense of things and in the service of trying to make people's lives better. And so I'm not, I don't have a problem with it from that point of view. It's just that from a from a sort of, I guess I'm quite scientific in the way I think. Show me the evidence. When someone can develop a blood test for depression, or any of the other 270 so-called disorders, then maybe I'm on board at that point. But until then, we've spent decades trying to find biological markers, at genetic level, all sorts of other levels of something like a marker that says this is the gene for schizophrenia or whatever. We haven't found it. So that's my objection. I don't think there's a scientific foundation for it. So therefore, I find it hard to get on board with approaches that really medicalize what I would see as relatively normal human experiences.
Yeah, medicalize and I could probably also argue stigmatize. Once you apply those sorts of labels that some of these second wave models and manuals do, I can imagine that it can almost sometimes feel like an additional weight for the client to carry at points.
Yeah, maybe. I think I would hopefully have enough humility to also recognise that there are people who find it hugely helpful. They find a diagnostic label really helpful because it means, right, I can go and find some information about this. I can find a support group. I can at least feel like I'm not the only one. So I think, it's like everything, right? Pros and cons. But I have some scientific objections, I suppose, to just treating like generalized anxiety disorder as if it's somehow completely different from depression, because that's just not what the data tells us. If you look at that famous national comorbidity survey that was done again back in the 1900s, but I think it probably still holds up. It was like an 80% overlap, right? 8 out of 10 people with depression will also have GAD. So it's like if you think about that as a Venn diagram, with the overlap being 80, so let's say you got 10% of people, you say, well, yeah, that's GAD. This other 10%, that's depression. Then you got this 80%. What the hell have they got? Like, if you've got a diagnostic system that can't reliably discriminate between these two different conditions, what's it for?
Great question. And I suppose we could end up talking about this all night, but I suppose I'm wondering, how have we gone down that path? What are the benefits of embracing that way of working with mental health?
Well, neither of us would have a job if they hadn't gone down that path, right? You've sort of got to play the game that's being played. And so I think, I don't have any animosity towards Beck. Like, he's a lovely guy. On the one occasion that I met him, he was very nice and he was very polite. And that's my, everyone else says that about him. He was a nice guy. He was a scientific pioneer. And, without him, none of us would have a job. And millions of people that have received a service in the UK would not have had it. So I don't, no axe to grind there. So I think that, but we undeniably live in a culture where the dominant view of emotional distress is a medical one. And so I think Beck recognised that and got on board with that, and we are where we are. And and that's fine, right? It's just that I don't have to agree with it. I'm allowed to have some kind of scientific and philosophical objections, I think, and I think I can still be useful to people. I mean, the interesting thing that I get asked a lot, because I'm known for ACT and training and writing books and things, but I also run the high intensity training course and have done since. I mean, I've been involved in it since the start. Like I was an external supervisor on the very first cohort in 2008. I was part of the course team in the second cohort, and I've run the course since the third cohort. So since 2011, I've been running it. It occurred to me as I was sort of preparing for this, thinking, I wonder if there's anyone who's been doing that longer than me.
Wow.
There maybe, I honestly don't know. So I've been very much in this sort of Beckian CT world, running NHS Talking Therapies training courses for the last 15 years. And yet I'm this kind of ACT guy. So I do get these questions like, well, how do you sleep at night? What are you doing? Like, and which is best, like ACT or CBT? And, honestly, I sleep all right. It's fine. I think there's lots of different ways to approach distress. It's useful to have a bunch of tools in your toolbox. I'm really glad that I learned cognitive therapy, that I learned REBT, that I've learned ACT, and that I can kind of choose from that toolkit to be helpful to people, and I can recognize there are some times when a certain approach is going to be more or less appropriate to someone. I think there's room for all of us.
To follow on from that, and going back to what you mentioned earlier, when you started your journey in terms of REBT and CBT training back in the good old, bad old days, you were told that formulation was basically, here's a blank piece of paper, you guys work it out together. And I suppose in a similar way, ACT kind of starts off in the same place, I guess, right? In terms of there is a type of formulation that you can use, but until you draw those two lines on the page, it is definitely very blank. And with that, ACT is obviously very transdiagnostic in itself. I envision it as this open field for exploration and experimentation. I can imagine that some trainees could be quite scared by not having the guardrails of a protocol or heavy manualization. And with that high intensity course hat on, our protocol driven sort of second wave models essentially at some point safety behaviors for a therapist or a trainee therapist. And if someone has been working in a very protocol driven fashion, how does someone manage that fear factor that comes with the freedom of not being stuck in that way of working anymore?
That's a really interesting question. And again, you're probably going to have to rein me in because I could answer that in all sorts of different ways. I mean, the one thing that's probably, again, from being intellectually honest, it feels like I'm about to say something really heretical, right? The BABCP listening.
I doubt it.
The evidence base for formulation hasn't been established. So it's rare that protocol-driven CBT and formulation-driven CBT have been compared in a research trial, but when they have, there's no difference in the outcome. So I absolutely understand from a trainee point of view, there's a certain safety in having a protocol and kind of knowing the steps. And I don't think there's anything wrong with that. I can remember back in the 90s, when I was learning CBT, I went into every session with a sort of bullet point plan of what I was going to talk about. So each session was protocolized, never mind the entire thing. Because when you're learning, it's useful to have a guidebook or a roadmap or whatever you want to call it. It's like if you drive somewhere for the first time, you're probably going to use a sat nav. That's fine. I mean, let me ask you. You've been qualified a good few years now. Do you think you rely less on protocols now than you used to?
100%. I think I'm going to say something that might shock you in that I don't think I was even that protocol driven when I was on the course, to be honest. As someone who
outrageous.
I better send my certificate back in the post. I think because I had experience of working with clients in, I guess, a bit more of a counselling-y type way, I think that better prepared me to kind of improv in sessions and sit with what's happening in the room and tailor what I'm giving to what I'm receiving, rather than going, we need to fill all these boxes and stamp out all the numbers on this bingo card, because otherwise we're not going to get where we need to go. And so I think and this is actually possibly a drawback looking back on it now, because I think if someone asked me, what should happen as part of this protocol? Like, can you list me all the boxes in this particular formulation? I couldn't tell you. I wouldn't be able to tell you. I'd have to look at it and read off it for a bit, because I suppose for me, the most important thing is what the person is showing up with in the room, because it doesn't always fit into the neat little boxes that formulations expect them to.
Yeah. And I think that's a very reasonable answer. And I think ACT is fairly similar. So like you can find ACT protocols. I mean, ACT is a very active research community. It's managed something like 1,500 RCTs since the first ACT book in 1999. So, and they're coming out about 2 a week now. So there's a very active research community, and obviously to do research, outcome research like that, you need protocols. And so there are loads and loads of ACT protocols. And I think that more seasoned ACT practitioners would probably rely less on them, and it would be more free-flowing. It's probably useful to say, just for people that may not be familiar with the model. So if people are familiar with, Michel Dugas, the Generalized Anxiety Disorder Protocol, Intolerance of Uncertainty, like that's a protocol that discourages you to get into the weeds of exactly what people are thinking and encourages you to think more at a process level. So to think about, there's this process of intolerance of uncertainty, or there's this process of cognitive avoidance. ACT is very similar. in the sense that it's process driven. It's very behavioral. It's not really interested in changing people's thoughts. It is interested in the amount of power that thoughts exert over behavior, and weakening that link. But I could, again, this doesn't work very well on radio, but if you can imagine a 5 areas model, and if you think, well, behavior therapy targets the behaviors box, we're trying to change the form of people's behavior. Cognitive therapy targets the thoughts box, we're trying to change the form of people's thoughts. ACT is more like targeting the arrows. It's kind of like saying, just because you think this, it doesn't mean that you have to do that. Or just because you feel, like you can't go to the supermarket, doesn't mean that you can't go to the supermarket. So perhaps you could go to the supermarket, and like, if that's a valued activity for you, if it's something you'd like to do, and we could work together to try and figure out a way to reduce the impact that your thoughts and your feelings are having on your going to the supermarket behavior. So it's like teaching people a bunch of skills to help them experience discomfort and do the things in life that are meaningful. So I always feel like there's 2 prongs to it. There's the kind of building up people's repertoire of valued activity. So that's sort of twofold, in the sense of encouraging people to get closer to what really matters to them. So as my mate put it the best, Ben Sedley, he said, figure out what you care about and then go and care about it.
Right.
It's sort of like there's the sort of value part and the behaviours. There's no point just clarifying your values, like, I really care about the environment, but if I don't buy a bamboo toothbrush and take my recycling out, what's the point of having the value? So it's that values clarification, value-driven action, that's one side of it. And then the other side, I think, is about learning to develop tools that help you do that. So tools that might help you accept the presence of uncomfortable thoughts, or tools that help you kind of stand back from your thoughts and sort of watch them in a less, more detached, less judgmental way. So like tuning in, showing up, figuring out what's important, and then go and doing it, and practicing, if you need to, methods for helping you be less distracted and put off by the thoughts in your head that say, don't do that, or you can't do that, or you're not worthy of doing that. For trainees, I think my message would be just focus on learning your traditional second wave CBT stuff, because that's the vast majority of the course. That's going to be the mainstay of what you've got to perform against. Those are the kind of, that's what you've got to produce in your CTSR. So I would focus on that. I think though, the other thing I would say to trainees is just I don't want my trainees to go away thinking that CBT was invented in Oxford. I think there's a very good evidence-based version of CBT that largely, comes out of Beck and comes out of Oxford, and the CBT world is bigger than that. And when you go out into the big wide world after training, you will very soon start to realise that the training prepared you really well for dealing with training cases.
Yeah. And
it perhaps hasn't trained you quite so well for dealing with complexity, working across different diagnoses. Clients don't know what disorder they're supposed to have, right? They don't fit neatly into the boxes in the way that you would like them to. And again, all the data we have about comorbidity just suggests that most people satisfy more than one set of diagnostic criteria at the same time. And so you're going to need some tools that help you navigate that complexity. And I think it's useful to be willing to sort of look outside of the traditional Beckian model, because there might be some really useful tools in there that help you think about that. And so for now, I would, largely focus on whatever the training course is designed to give you, and just sort of keep one eye open for the fact that there might be other tools out there that might be useful to you.
Definitely. And I think with those tools, it's about supplementing rather than replacing. And I suppose for trainees at that stage then, so perhaps on the verge of qualifying, or people who have just qualified as CBT therapists and they want to do a little bit more of that experimentation. You spoke about sprinkling value seasoning onto your second wave practice at the time. What are some of the other ways in which people at that stage can integrate ACT principles into their therapeutic practice, perhaps without feeling like they're having to abandon structure and fidelity entirely?
Yeah, great question. So, I mean, I think there's like 3 different strands that are useful. I'm going to repeat like the values bit. I think there aren't many interventions that can't be improved by a bit of attention to values. So if you're doing activity scheduling, like if you're going to get me to do an activity to lift my depression, I want you to make it meaningful for me. Like I don't want to go and do the dishes, right? Because it's doing the dishes is boring. But if you help me connect doing the dishes, like I'm doing the dishes because, what I did was just cook a meal for my partner so that we could connect. And doing the dishes is just part of that. Or standing in a queue in Tesco because I'm buying the ingredients for that meal, because this isn't about shopping. This is about connection. This is about love. If you can help me connect some boring, mundane activity to a higher purpose, I think I'm much more likely to do it. So I think like value-driven behavioral activation, value-driven activity scheduling, value-driven exposure. If you can ask me, well, what is it that you really care about? What kind of qualities would you like to have more of in your life? And if we could make your goals a bit more value driven. So I think values clarification for the amount of time it takes is really worth it. Have you got your phone?
I do, yeah.
So I want you to open your camera roll. Get your camera roll and just like whiz it, just whiz it, go back in time.
Yep.
And then stop.
Yep.
And find a picture that makes you smile or just speaks to you, and just, press that so that fills the whole screen. And I'm going to ask you to just sort of mentally play with that image. So like if it's inside, imagine it's outside, or if it was summer, imagine it was winter, or if there's someone in the picture, take them out, put someone else in. Like soon you're going to come across something where you think, well, I can't take that out, because if I took that out, I never would have picked this picture in the first place, right? You got that ingredient?
Got it, yeah.
So I want you to give me in one word, like what that ingredient says to you about what's important in your life.
Love.
Love. Right. There you go. So if we were doing your homework this week, my first question would be like, how could we get a bit more love in your life? Now that could be, I don't know, some kind of romantic whining and dining, or it could be just sending a text message to a family member. It doesn't matter what it is, right? It could be big or small. But I would want to make all my work with you relevant to love or other values that matter to you. So, I mean, I don't know how long that took, right? That took probably a couple of minutes. I don't know what's showing up for you right now.
A lot of happiness, actually. Just, and even again, just from viewing that photo, actually, and seeing something I connect with and resonate with really well, that already gave me the warm and fuzzies. But also it was a bit of a stark reminder to me that actually I kind of need to be more in the moment with stuff and not letting my head sort of be 10 steps ahead of me all the time.
Okay. So you asked me for some things. There's one, values, yeah. Right? So a little bit of values work. I mean, and there's, you can pick up any ACT textbook and find a whole bunch of values interventions just to preface other things that you might ordinarily do. I think you can do that without feeling like you're doing anything evil or wrong, or you've gone outside of traditional CBT too much. There's a really great article on the Beck Institute website recently about suicide prevention, and it was just values all the way through. No mention of ACT, but I think that's fine, right? I think you can see how ACT has really infiltrated mainstream CBT. And I love that. I sincerely hope that at some point in the future, we're not talking about like ACT versus cognitive therapy. We're just talking about evidence-based processes that, like, if you do interventions that work on these processes, then you help people. Like, I would be all in favor of less tribalism and more just joined up thinking, but values. Second thing I think is just about being more present, being more mindful. So bringing a quality to your sessions where you're there with the person, you show up, you are open and honest and vulnerable, and you are modeling to the client those things. Often clients come in and that what part of their problem is they struggle to be open, they struggle to be vulnerable, they are wedded to avoidance. One of the greatest things you can do is to just show them what it's like to be other than that. It's not about teaching people, it's just showing people. It's like if you didn't know how to build a wall, what the first thing I would do, right, is if we I invited you along to my wall building class, the first thing I'm going to do is I'm going to show you how to do it, right? I'm going to model it. I'm going to pick up some bricks and some mortar and I'm going to lay them. Embody the kind of person you want to be and show clients how to sort of interact in the world. So I think there's a sort of mindful quality that you can just bring to your work that would be very ACT consistent, but again wouldn't be betraying anything that's important in sort of traditional CBT. And then the third thing I think is just always consider that challenging a thought might not always be the best option. And I don't want to come off like I'm slagging off thought challenging, because I think it has its place. But it's good, I think, with facts, where there's factual information. I always remember working with this little kid, and he'd been in a serious car accident, and he was really reluctant to go in a car again. When I asked him why, he said, because, traveling in cars is like super dangerous. And I said, how dangerous? And he said, well, really dangerous. And I said, well, like, out of interest, how many people do you think get killed on the roads in the UK every year? And he said, about 3 million. Now, I was pretty sure it wasn't 3 million, right? So his homework was to go home and research causes of death in the UK. And he found out it was about 800, not 3 million. And he felt a lot safer. So, that's cognitive restructuring, and it works really well with facts. And I think the problem is that vast majority of the time we're not dealing in facts. We're dealing in opinion. I'm worthless. I'm a loser. No one loves me. These are more like attitudes and opinions about things. And when you start challenging them, if you're not careful about it, you can end up just in an argument or coming over like you're a bit invalidating. So I think just to consider sometimes, the response to I'm worthless isn't, let's just write that down on a 7-column thought record. The response might be, wow, that must be really, really hard for you. I'm so sorry. And I guess it's kind of understandable given the life that you've had and some of the lessons that you learned as a child that you think like that. And thinking about whether just allowing that person's mind to do its thing might be a more kind of kind way to go about things, and sort of perhaps thinking about, is there anything we could do that might be about behaving differently in the presence of that thought? Like sort of communicating that you can't choose the thought, but perhaps you can choose something about how you respond to it. And going down a more behavioural road, sometimes that might be more appropriate than trying to go on a search and destroy mission for those gnats.
I can imagine that being, I suppose, sometimes heartbreaking for trainees who go through a training year where they'll see videos of Podesky doing 7-column thought record, and it works a treat. And I suppose this will hopefully serve as a refreshing reminder that this toolbox that you're going to develop is going to be as big as you want it to be. If you want to stick to 7-column thought records, that's a path you can go down, and that's totally fine. However, other forms of assisting people and other forms of therapeutic intervention are available too. When people begin exploring the ACT pathway, what are the, I guess, common pitfalls that you observe new therapists falling into, perhaps when they start out playing with ACT?
If you think of CBT and go back to the kind of umbrella, there's a more behavioural end of the umbrella and there's a more cognitive end. ACT is down the behavioural end. It's not really interested in, as I said, changing thoughts, or it's not certainly isn't interested in the, like, is that thought true? It might be interested in the, like, does that thought help? Like, if you do what that thought says, does that help you? Do you feel like you're better off? It's down the more behavioural end. And so as a consequence of that, ACT training tends to be very experiential. One of the, I suppose, underlying assumptions within ACT is the best way to learn it is from the inside out. So you can sort of track the components of the ACT model, like how do you become more psychologically flexible? How do you track things like acceptance or values clarification? It's best to learn that yourself before you deliver it to other people. So there's a heavy emphasis on experiential learning. And so it's not uncommon. In fact, it's probably the most common bit of feedback I get from ACT training is like, wow, this was so helpful to me personally. And I wasn't expecting that. Or, people are in tears by morning break. And I think one of the mistakes that people get into is that like if I haven't made someone cry, I haven't done ACT properly. Like it's got to be this really hard hitting, emotionally punchy intervention, and it doesn't have to be like that. If you're not doing it carefully, the acceptance message can come across a little bit dismissive. I think if Steve Hayes and co had their time again, they probably wouldn't call it acceptance and commitment therapy. I think there's a bit of a view there's something a little bit kind of sucky about that title, because acceptance has a lot of other connotations. Like people think it's like, what? So I've just got to accept everything then. I've just got to wave a white flag and let life steamroll on me, and I've just got to accept it, or I've got to accept this horrible suicidal thought. And I think people perhaps can do that in quite an unskilled way, such that it doesn't come across in a very validating way. When I'm talking about acceptance, it's really an inner acceptance. And sometimes a better word is willingness. Like, can I ask you a question?
Yeah.
Like, you did the training course. So we know what you were doing then, but like, if I could ask you sort of a values question, like why were you doing it, in terms of what was the compass that was pointing you in that direction? Why did you want to train to be a CBT therapist?
Connection, I would say.
Okay. So there you were doing this thing that was about connection, and you were, there were probably many times when you were outside of your comfort zone, and I've heard you talk on other episodes about that, and I, running the course for as long as I have, I know exactly what that feels like. Would you be willing to say some of the uncomfortable thoughts or feelings that arose in the service of you, trying to get more connection in your life?
Yeah, this is too much for me to handle. I'm not going to be able to do this. I think I'm failing at this. I'm not going to be good enough.
Okay. If I said to you that, like, if I could take one line from all of my, whatever it is now, 30 plus years study of psychology, it would be this one, that like in your pain, you find your values, and in your values, you find your pain. They are like two sides of the same coin. It's not possible to do something as sort of outside of your comfort zone and repertoire expanding as CBT training, even if you do it for the most noble of reasons like connection. It's not possible to do that without experiencing some discomfort. So all of those, they sounded quite painful, those thoughts. I noticed myself as you said them, it's like, wow, that can't have been an easy journey.
It was difficult. It's interesting looking at it in the rearview mirror, because I think I've got a tendency to downplay how difficult it was at the time. But yeah, it was difficult.
But what if I was to say to you that those things were like entirely normal? They are what happens when you step outside of your comfort zone. When you take a value-driven decision to step outside of what's comfortable into the unknown, it's why they call it a comfort zone, right? Because it's comfortable in, and as soon as you get out, it's uncomfortable. But that is just what happens. There's nothing wrong with you. There's nothing disordered or symptomatic about those thoughts. That's just those thoughts are the price tag of you making this courageous decision to expand your life. What shows up for you as I say that?
That's a good question. A sense of honour and courage, I think, in terms of actually surviving those rather painful thoughts and making it through to the other side of not only that training course, but then clearly engaging in the vicarious pain of continuing to make a podcast that centres around the training journey.
So if I was to say that, like, those thoughts are the price tag, right? They're just the price tag of you serving your value of connection. Nothing wrong with you. That's just what happens. Like, it's like the Queen famously said when Prince Philip died, like, grief is the price you pay for love. It's this two-sided thing, this two sides of the same coin, values and pain all wrapped up together. And that the task for you during training, and maybe even now, right, is how do I make these thoughts go away? The task is more like figuring out if this training is something that's worth suffering for, or this podcast, or this job that you do, or this supervision role that you've just taken on? You know, is it worth suffering for?
That's a great question. And I would say, yeah, of course it is. Otherwise, I guess I wouldn't be doing it, right?
So if we establish that, then what if the next time, like, I'm not good enough shows up, rather than see it as like some kind of enemy that you've got to vanquish or you've got to challenge or change or get rid of, what if you could see it as like a messenger? It's like this is my value sending me a message. Like, here's this really important thing. Like, it matters so much to me that I'm getting upset about it. It's so important, and that like this feeling is not something I need to squash or get rid of. What if I could lean into it? Because actually, this is a reminder of how much I care about this thing.
So just hearing you say that, actually, I'm wondering if there's a bigger systemic and societal issue at play where we've sort of sleepwalked down this path where people feel as though they always need to numb their feelings or not pay attention to what those feelings actually mean, and that we're caught in this cycle of just doing all the time rather than sitting and feeling and actually interrogating ourselves as to what does this stuff mean inside of me right now?
Well, yeah, absolutely. I mean, I think we live in a culture that kind of supports that. It's sort of like this sort of happiness culture where you're just supposed to feel good, and if you don't feel good all the time, then there's something wrong with you. That's why I loved Inside Out. Remember that movie that came out? It was like, this is the best thing that anyone's ever made. Like, this should just be required viewing on your first day at senior school. You know, the idea that you are a human being, you have a range of different emotions, they're all evolutionarily adaptive. You know, there's a reason why we have anxiety, the reason why we have anger, you know, all those yucky. I mean, there's only one nice one out of those 5 emotions. It's only happiness that's nice. The other ones are all horrible. But there's a reason why we have them, and there's nothing wrong with you if you experience those. That they are not things to be gotten rid of. That they are things to listen to, and because they tell you something about the world and your experience of it. But yeah, we're in a culture that doesn't really portray that message. We're in a culture of like, if you're feeling bad, then you know you should get that fixed. And you know, and I just think it's a genuinely quite unhelpful message.
Speaking about culture and dynamics in the therapy room as well, some clients I think still expect the dynamic of I'm the client, you're the expert, and I'm wondering how you find the lack of hierarchy within ACT impacts on what plays out in the therapy room, and would you say it's still feasible in a system that contains an implicit hierarchical message when we think about how lots of talking therapy services operate, for example? And I'm wondering how you'd also navigate situations where a client would like there to be a hierarchy.
I'll tell you this little story. I mean, this is like everything and nothing, this story. But so I've been to several Steve Hayes workshops down the years. But the first time I met Steve, it was at a conference in Dublin. And so it was lunchtime, right? And I'd got my lunch from the buffet, sat down at the table. My hotel room was in the same building, and so I just realised I'd forgotten something. I went upstairs to get this thing, came back. Steve's sitting next to me, right, sitting in the next seat, and he just turned to me and offered his hand, and he went, "Hi, I'm Steve." Right, and like, I know that's nothing in the sense that that's just what normal people do, but I was like, "Yeah, I know who you are." But it's just the sort of the humility of just like, everyone knows who he's. Professor Stephen Hayes, the originator of ACT and relational frame theory, and you know, he's this sort of psychology legend. And he has the humility to just turn to me and say, "Hi, my name's Steve," and offer his hand to shake. And you know, I've heard the same thing about Carl Rogers. You know, he used to say, "Hi, I'm Carl." You know, and it was very personable. So there is something about the ACT community that's hard to describe unless you're sort of part of it. That people are just very decent, and I wonder if it's something about the emphasis on values, that this isn't a thing you just talk to clients about. Like, this is a way of life, right? That you it's important for us to model the model, and that it's important to tune into your values and enact them all of the time. And so I find that being part of the ACT community is probably the highlight of my professional career, just because people are so decent and value driven, and that's not to say there aren't fallouts and conflicts, but there's a humility in it that I've not seen anywhere else. I mean, one of the things Steve said when I interviewed him once for a podcast, and he said the ACT model is wrong. We just don't know how yet. And it's that sort of the humility to say, this is just our best stab at trying to figure out what's going on. But he would be willing to tear the whole thing down if the evidence and the data didn't support it. And he's kind of moving on in a way. Like, he's still an ACT guy, but he's very much into process-based therapy. Him and former arch enemy, Stefan Hoffman from the sort of traditional cognitive therapy side of things, the two of them teamed up. They wrote a book, Process-Based CBT, and that's where they're going. They're trying to build a kind of meta model, really, of CBT. So yeah, there's a flatter hierarchy, I think. As for the bit about clients, like, I've definitely changed in my practice. I've become a much more open therapist, much more willing to be vulnerable, much more like ready to use things like self-disclosure, for example, cry in sessions if I feel moved, rather than feeling like I have to somehow censor that or be something different to who I am. Obviously I'm going to maintain professional boundaries, but I think within that, I'm just much more of myself, and I'm not putting on a therapy voice, or I'm not kind of acting in a way that I think perhaps I used to when I first started. And I mean, I've not got any data for you, but all I can say is that I think clients respond well to a more human, genuine, honest connection in the therapy room.
I can imagine that's also perhaps taken the weight off of you as well, in terms of just being able to be unashamedly, authentically you. I suppose going back to the last part of that question, though, so how would you navigate situations, again, thinking about some of the talking therapies settings that we're operating in, where clients sometimes would like there to be that hierarchy of I'm broken, you fix me?
Yeah, see, I'm just not playing that game with people. I'll often joke about it. Like, did you see that massive queue outside the door? Did you see that huge queue of clients that was snaking off down the road? No. That's because I'm not some sort of guru miracle healer, and that's not what's going on here. I'm like the cheerleader, not the guru. I'm the kind of person who's going to help you, and I'm going to bring my expertise of psychology, and we're going to put that together with your expertise of your knowledge of you. Nobody knows you better than you do, and this is like a team enterprise. But if you think that I've got some sort of cure up my sleeve, then I'm really sorry to disappoint you. The other, on a more sort of serious note, I think that ACT would take the view that there's no fixing to be done here because you're not broken.
Yeah.
And I've said that to people in as many words, like, I don't see you as broken. I don't think there's anything to fix. And I suppose one of the areas of tension, just thinking about your question and the high intensity environment, like, people have to fill out these questionnaires every week, right? The GAD-7 and the PHQ-9, and the implication of those is that you start high and you scores reduce over the course of the sessions, and that's how the service is measured in terms of its sort of performance. I have a bit of a problem with that, just because we're sort of making the argument there that less anxiety is good for people, or less low mood is good for people. And again, my objection is a scientific one, because the data just does not support that. That, I mean, imagine I said to you, I don't know, tomorrow you are going to appear on, I don't know, Diary of a CEO or Joe Rogan or something massive, right? So there you are, podcast sort of guy, but like, you're going to have to make this massive leap. What would show up for you?
Anxiety.
Right. Welcome to the human race, right? This is just kind of what happens.
It's really interesting thinking about this in context, in terms of the medical model is on this path of kind of saying, well, yes, less anxiety is better for you. Yet, as any budding therapist out there might know, we spend a lot of our journeys on psychoeducation and talking to you about how anxiety affects 100% of people on the earth. And I don't know about you guys out there, but that sounds like quite an uphill battle. I don't think you can win on statistics alone against a 100% probability of feeling symptoms of anxiety, which then leads you to think, well, how does this all fit together as a puzzle? And it also makes me question, well, how did people buy this?
Yeah. I mean, I don't it's going to sound really corny, but I don't want people to be less of anything. Right, I'm not in this to help people sort of reduce themselves. I want people to be more of themselves. And I mean, just on a scientific basis, like there are systematic reviews of these kind of measures, and you would expect that if anxiety goes down, quality of life goes up. If depression goes down, quality of life goes up. That's just not what happens. That because for the reason that you just sort of explained there, like if you were to do something really exciting that's going to take you out of your comfort zone, your anxiety is going to go up. Is that a problem? Like, is something wrong with you? It's almost ridiculous, right? And so people engaged in therapy whose anxiety scores go up, often that's because they're living a bigger life, and that's not a problem. But for the service, that's sort of seen as a problem, and so I think there's something inherently a little bit difficult about that whole relationship. The work and social adjustment scale is my favourite one.
We'll come back to the outcome measure stuff. We've received a listener question, so we'll come back to that in Socratic questions later on. You spoke earlier on about values being adopted by the wider cognitive behavioural therapy community, and my memory may be wrong here, but I think you may have shared that on what was known as Twitter at the time, and I think you received a response from a rather prominent voice within cognitive behavioural therapy who essentially suggested that ACT was old wine in new bottles. And I'm wondering how you respond to people that have that train of thought.
Yeah, Twitter. Well, I remember that. I get it. I think that kind of comment is often, well, it's leveled at lots of different things, isn't it? And with some reason. I mean, like if you think of, I mean, probably other people would even dispute this, but if you said like Albert Ellis and REBT, that was kind of the original form of what we'd recognise as being sort of CBT. Somebody wrote a book, Emmett Velton wrote a book called Under the Influence, and it was an entire book about how everyone had ripped off REBT and they'd called it something else. And there was a chapter on Beck and there was a chapter on ACT. Emmett Velton was murdered, strangely. Well, those things probably not connected, but that's a weird fact for listeners. But yeah, I think there's a certain sense in which we're all standing on the shoulders of giants. I think the idea of waves is it's a good metaphor because, like a wave hits the shore and it changes the shore, and the shore is never the same again. And then, when the second wave hits, it couldn't have hit had the first wave not already hit. Like it was sort of being carried by the first wave. It's an iterative process. And so I think there's going to be ideas in ACT which are not new.
I think to deepen that metaphor as well, the second wave is still made up of the same water. The water doesn't go back again and suddenly recomprise and change into a different substance. It's the same stuff in perhaps a slightly different form to what it was in the first wave.
Yeah. And I think that's a fine thing. Like I'm not practicing now in the same way that I practiced in the 90s when I first learned about CBT. And that's a good thing, right? And I hope if I'm still doing this realistically, I don't know how many more years there are, but like let's be optimistic. Let's say I'm still doing this in 20 years' time. I would hope that I'm practicing differently again. The idea that I'm doing exactly the same thing that as I'm doing now is a bit depressing, right? But and that's how science works, right? It's an iterative process, and we change. I do get frustrated with the sort of some elements of the second wave CBT crowd just thinking, well, what, we don't need this. We've got cognitive therapy. Why do we need ACT? It's what are we just saying? We're just going to stop now? Then we're just sort of frozen in time. We've reached perfection. Only 50% of the people we see make improvements. It's not good enough. We need to keep going. We need to keep refining. We need to keep researching processes of change and mechanisms of change. And the way that we practice will continually develop. And that's exactly what should be happening.
And there's an inherent beauty and excitement in that. I think sometimes people make the mistake of deciding on this as a career path and then feel as though it's going to be a bit samey, sort of cut and paste day in, day out. But I think within this is an inherent opportunity to develop and be fluid as a practitioner, move with the times, move with the world, and expand your toolbox as you move forward and expand with shifts in culture and society as well. And I'm also wondering, looking from the outside in, there have been curricular changes that have seemingly curtailed the flexibility of universities to be able to include things like ACT on high-intensity courses. Firstly, I'm wondering your take on why that was, and I'm also wondering, as someone who is a proponent of ACT, and as someone who's clearly incredibly passionate about it, I'm wondering how you responded to that change happening.
I was a bit disappointed. I was disappointed with many elements of the most recent curriculum revision. I was expecting it to be more radical than it was.
In what way?
Well, I think that there's a direction of travel in CBT broadly, which I think is moving away from disorder-specific approaches into a more transdiagnostic way of looking at things. And you'd have to be blind not to notice that how much the average caseload of a high-intensity therapist has changed since 2008. IAPT, as it was back then, started as an outpatient psychotherapy service for people with mild to moderate mental health problems. Now, I was supervising someone the other day, a year post-qualification, and described to me a case of someone who was in the UK on a spousal visa, victim of domestic violence. So therefore, once husband had been deported, this woman no longer had a right to live in the UK. So she's waiting for the axe to fall. So she's living with the trauma of the abuse in the relationship, living in a women's refuge, getting messages from a country of origin saying, as soon as you come back here, he's going to cut you into little pieces. What are you supposed to do with her? Really, yeah. It's in 12 sessions. It's very difficult. I think there are forces at play in society, increasing wealth inequality, for example, cuts to public services, and the sort of squeezing of the middle class that, we're all feeling it, right? Everybody, unless you're super rich, like everything is more expensive and your wage packet isn't going as far. There's a sort of rising tide of racial tension, and politics is becoming really polarized. There's a whole bunch of factors which just make the cohort of clients much more complex to work with. Where are all the spider phobics? Where have they gone? So it feels to me, what I was wanting from the curriculum change was a more progressive acknowledgement that the kind of people that NHS Talking Therapies sees now have changed. We're getting much more social deprivation, much more neurodiversity, all sorts of reasons why people are more complex, and they don't easily fit into these disorder-specific boxes as well as they used to. Services are under pressure to increase sort of performance, so they've sort of opened the doors to everybody. Let's get more people through the system, as well as being more stringent on the amount of sessions that therapists are allowed. So I was hoping that we would get more of a transdiagnostic focus, more of a, well, maybe that was my main thing. And I was disappointed then to say, well, no, actually, you've got to spend more time teaching on PTSD and more times teaching on social anxiety. And, I get it. There's the national outcomes for those presentations weren't so great. So they think that the answer is more time on the training course. I don't think that's the answer. I think there's other stuff going on. So I was a bit disappointed. They specifically outlawed anything that isn't in the NICE guidance for anxiety and depression. ACT is in the NICE guidance for chronic pain and tinnitus, I think. But, NICE guidance is slow to react. I'm very fortunate to go to quite a lot of international conferences. The discussion there is more about complexity and transdiagnostic processes. And in the US now, if you just want to do some kind of disorder-specific research, they're much more reluctant to give you a grant, because it's like, well, you've had 60, 70 years researching this stuff, and outcomes for people have got worse, not better. Maybe everyone doing their own sort of silo research hasn't really helped. And so I think the research focus ought to be more on sort of mechanisms of change and working together, less tribalism, more working together to try and find out how best to help people. So it felt to me like a bit of a missed opportunity. And it was a bit telling when I got the final draft, there was it's a big long document, right? But on the front page there was a summary of the changes, and the outlawing of anything that wasn't in the NICE guidance was in there twice. Like it's like, well, I think you might be protesting too much. It's like someone's got so enthusiastic about outlawing anything else that they've said it twice. So it did make me wonder whether there's some kind of a bit of somebody's feeling a bit threatened, or there's something a bit defensive about it. It's just, but to put my own sort of preferences aside, I just think it's a bit of a shame because when we taught ACT specifically on the course, people loved it.
Yeah.
And I don't think people sort of saw it as being disrespectful or problematic. It was an adjunct. It was like, right, we've done all the things we're supposed to teach you. We've delivered the curriculum. Here's a few extra days. They were extra. We taught more days than we needed to, and we did it because there's some local expertise in it, but because we genuinely thought this was a useful addition to people's toolbox, so that you've got all of your traditional second wave skills, and here are some others that you might want to use judiciously if you find yourself in a tight spot with a client. Genuinely, the feedback was really great about it, and people thought that was a really useful addition. So it just feels like it's a shame that we're not doing that anymore.
Well, yeah, and as someone who got to enjoy those training days, I definitely concur with that point of view, in that at no point was it combative, at no point was it, this is what you should be using instead of the second wave diagnostic specific stuff. It was a fantastic extra room, extra shed of tools that you gain access to. As you said, particularly if you find yourself in a bit of a tight spot with a client and you've tried all the second wave skills, you've tried everything that it tries to get you to do in a manual or a protocol, and you want to try something a little bit different, I think it was a fantastic set of skills to incorporate. And I suppose what I'm hearing from you there is the sense that more than anything, this is a step backwards. And these are my words, not yours, but I'm also, I get the feeling here that there's a serious case of ivory tower syndrome going on in terms of people at the top designing a curriculum without a real understanding of what happens at the ground floor. And I suppose I'm curious, and please correct me if I'm wrong here, am I right in thinking that you're a member of the special interest group on ACT or third wave therapies within the BABCP? Is that right?
I was. It folded strangely. It went from being having I think I'm right in saying the biggest membership of any special interest group to then folding, just
That's
because
odd.
it was hard to get people on. Sometimes you just have a golden moment and there's a bunch of really enthusiastic people on a board, and then you struggle to replace them. And yeah. So I'm a member of ACBS, which is the Association for Contextual Behavioural Science. So that's the kind of mothership of all things ACT and RFT and functional analytic psychotherapy.
I suppose the reason I was asking in relation to the BABCP was that I was wondering if there was any opportunity to make some kind of sea change and actually turn the tide in the favour of a more transdiagnostic approach that accommodates the sorts of presentations that we're having to deal with nowadays.
Well, there's an interesting, I don't know if you're even aware, because you're very much steeped in the high intensity way of things, but the BABCP actually has two separate core curricula. So there's the high intensity one, and then there is their core curriculum for non-accredited courses.
Right.
So they're not the same document. If you let's say you're a clinical psychology program and you want to start offering accreditation, you would look to the BABCP core curriculum. You wouldn't look to the high intensity one because you're not offering high intensity training. So the curious thing is that one, which I was advisor on, has, I think, a more progressive, more inclusive feel to it. So it includes some contextual approaches. I won't bore you with the details, but it felt like that one is a bit more forward looking, and the high intensity one is more wedded to a disorder specific way of looking at things. And again, I don't want to come over like I'm some old sort of curmudgeon, and I understand my job is to deliver the training in NICE guidance so that the workforce can go out and deliver the stuff that's in the NICE guidance. I get that and I accept that. I just think that times they are a changing and the curriculum isn't changing quite as, it's not quite keeping pace with that. There was some good stuff in it, don't get me wrong. There was some good stuff about diversity. There was some stuff in there about working with complexity. I just would have liked it to have gone further.
As someone who obviously hasn't been on the course for several years, if it wasn't through an ACT or a third wave lens, how was this working with complexity stuff navigated then? What are they suggesting?
That's a very good question. Yeah, there wasn't there wasn't any sort of prescription about how you should do that. But I guess the implication is that we should do that within kind of, within existing, traditional second wave methods, which is fine, right? Like I think that's probably doable. For example, we have a day on our course on, well, we have 2 days actually on transdiagnostic working, which is all about working with complexity. And so we talk about David Barlow and the unified protocol. So there are more traditional voices, I suppose, that are addressing this kind of stuff. Given that ACT, it's recommended by the World Health Organization. It's in the national guidelines of a number of different countries. I think, like, it won't be long, right? The evidence base is big and growing. It won't be long before that happens.
I'm glad you said that, because I think that moves me on to what I wanted to ask next, actually, which was, you mentioned earlier that we're running at roughly 2 RCTs a week, I think you said earlier. Where's ACT going next, and how do you see this evolving? How do you see the distance between it and public therapeutic systems in the UK changing as the landscape evolves?
Yeah. So as luck would have it, it's the UK ACBS conference this coming weekend. And I am part of a panel discussing this sort of very issue about like training standards and dissemination. So one thing that your listeners might be interested to know is that ACBS does not have any kind of accreditation process for therapists. It's taken, like, again, a values-driven decision to not police therapists. So there is no such thing as an ACT therapist. There's no one accreditation or certification you can take, no license. And it's done that deliberately because it doesn't want ACT to, because to do that, you have to say, this is ACT. Like the bit we've just been talking about, BABCP said, this is CBT, this is the curriculum, this is what you have to learn. And I totally understand why they do that.
And I can also imagine as well, with that comes an inherent hierarchy, right? You have the badge and you don't.
Well, there comes that. The other thing that comes is a sort of ossification, because you have to say, right, this is CBT and these are the things you need to learn, and you can't change it every 2 minutes, right? Yeah. So almost what I've sort of just been complaining about in a way, which is that it doesn't feel very progressive, feels a bit stuck. That's the downside of having a sort of like a clear and defined curriculum and a clear sense of what makes a CBT therapist and what doesn't. So it creates the hierarchy, it creates a sense of like just feeling a bit stuck. It's kind of hard to be progressive. So ACT is a lot more nimble in the sense that it can develop, and there's all sorts of different versions of ACT. Like there's something called DNAV, which is a development of ACT for young people and adolescents. There's pro-social, which is a version of ACT developed for use in organizational psychology. Like, ACT isn't really a thing so much as an approach which you can then bend into different things according to different situations. So it's more nimble in that sense. And as I said earlier, Steve Hayes is very much taking the spirit of ACT and developing that into process-based therapy. The downside is that without a clear certification or accreditation procedure, how do you tell? How does the public tell who's a good ACT therapist and who isn't? Like, without blowing my own trumpet, right? I've done hours and hours and hours and hours of CBT, thousands of hours of practice. I'm a ACBS peer-reviewed ACT trainer, so that's the level of policing they do, which is like there's a whole bunch of hoops to jump through to say that you're a peer-reviewed trainer. But how does the public tell the difference between me and someone who's done a couple of days, introductory ACT workshop and says on their Psychology Today profile that ACT is one of the approaches that they offer, and then they haven't done any supervision, maybe they haven't even bought an ACT book. There's no way of telling the difference, and that is problematic. So I think if ACT ever gets to the stage of being in the nice guidance for anxiety and depression, at which point the world and their wife will want it, I think ACT will have a problem, because it's not then easy to tell who's a sort of bona fide practitioner and who isn't.
How do you navigate that?
Come to the panel on Saturday. Hear all about it. I mean, it's happened in other countries. It's happened in Poland, for example. I was in Poland recently, and they were talking about this very issue, that basically if they had to be very quick and sort out some kind of licensing, accreditation and competency route, because otherwise the government said, well, we're not going to give you any funding for anything, or we're not going to recognise you as being a bona fide therapy. And I can understand that position. So yeah, I think it's interesting times.
Moving things back to a bit more of a personal standpoint, but also the relationship between the personal and the systemic as well. We've spoken a lot today about values and ACT being big on living by your values. We're hearing more and more about therapists experiencing burnout, sadly, both at trainee levels and also at more experienced levels as well. And listeners out there may have heard the bonus episode that we put out recently with Dr. Elizabeth Cotton on Uber therapy and burnout. And I suppose with that sort of system in mind, some people feel as though their values conflict with the values of the systems that we work in. And I suppose I'm wondering how you manage the balance of modelling the process of living by your values and encouraging others to live by theirs.
One of the things that really influenced me was reading a book called Man's Search for Meaning. And forgive the title, it was written in the 1950s. So women did exist then, writing conventions of the day. And it was written by a guy called Viktor Frankl, who was a psychiatrist who was Jewish and imprisoned in Auschwitz during the Second World War. So he was a prisoner of war for 3+ years or so, and he wrote a book about his experience. It's hard to imagine a more aversive situation than that, right? Like being interred in a concentration camp against your will, death and destruction all around you, not knowing whether you're going to live, to see another sunrise. And he said, obviously that experience affected people in different ways. And one of the things he talked about was this idea of even in the midst of all of that, people could sort of still choose who they wanted to be. Like it's sort of like the last thing people can take away from you. So he said he saw people who just almost like decided to die. You could kind of see the light went out of their eyes and they'd be dead by the end of the day. They just had enough. There were people who, in return for better rations and a better chance of survival, became what they called capos. It was like an enhanced sort of prisoner. So you would join in with the Nazis, you would brutalize other prisoners, you would, in return for probably a better chance of surviving. And then he said he also saw people who gave away their one piece of bread a day. They'd give it away to someone who needed it more. It's sort of like, it doesn't matter how bad things get, you can still tune into your values and decide who you want to be and what's important to you. So is survival more important to you than kindness, for example? I don't want to make any judgments about what people chose to do, because who knows what I would do if I were in that situation. So I suppose I'm quite an ardent believer in no matter what's going on around you, you can still make a stand, even if it's a small one, So, I think NHS Talking Therapies is a wonderful thing. I think it's a great humanitarian project, and lots of other countries would they'd cut off their right arm to have, a service that we've got, like where you train people to this really rigorous standard up and down the country, and they go into a public healthcare system and give that away for free, that's amazing. And there's lots of things wrong with it, right? There's lots of things wrong with it. You work there on a day-to-day basis. It's stressful. People get burnt out, targets and all the other kinds of pressures. I think one of the ways of coping inside of that is to make small value-driven commitments, deciding who do I want to be in amongst all of this. There's the good and the bad, but I can still make some kind of choices about what I do, what I want to stand for, how I'm going to align my behaviour. So I think when I've been invited to do team away days, I usually use ACT as my inspiration for that, and I help people think about mindfulness and acceptance and values as tools to help them navigate a world that's frequently very stressful.
I think that also speaks to the point you said earlier about ACT not just being a therapeutic approach. It's a way of life. Sometimes the tools that we work with are tools not just for us to share with others, but to also be embodied as we go through the journey as well. And for our listeners out there, if you have any questions about ACT or any other items that we have covered across the podcast, please get in touch with us at hello@twolostsouls.co.uk. And that is exactly what Matt in Manchester did on our segment called Socratic Questions. So this is from Matt in Manchester, and Matt says, "Hi Ravi, Shell and Dr. Rich. I finished my CBT training about 6 months ago and have been trying to learn more about ACT and integrate it into my practice with varied success. I thought this would be a good opportunity to get some help with some of the challenges that I'm experiencing. I've been able to get clients to engage with things that they value and enjoy, but they complain that while they're connecting with the things that they want to, their mood isn't really following. Their questionnaire scores are stuck in caseness. How do I navigate this given that my service wants them to be in recovery?" He also says, "Some of the clients that I work with find a few of the metaphors quite twee or flowery, and I think this sometimes alienates them. I've tried to co-produce metaphors with them, but they struggle with this, and I then struggle to convey complex ACT concepts in other ways. Where do I go from here?"
Okay, Matt. Well, 2 questions there. If I take the first one, I mean, this is tough, isn't it? It's that clients are making change and they're doing that in a values-driven way, and maybe it's not quite getting them the desired result. 2 issues there, I suppose. One, it's not getting them the desired result, but also it's not showing up on the questionnaires, and so the service isn't getting what they want out of it either. I mean, firstly, like if it comes to a decision between satisfying the service and satisfying the client, like there is only one winner there in my book. So if somebody's scores go down, then great. If they don't, I'm not that worried about that, as long as the person has found the interventions to be useful. And I suppose I don't know, I'd love to talk to you about it more, but one of the things that might be going on here is that people are just falling into the same trap of using a kind of ACT intervention to try and get rid of stuff. And that's kind of not the point, right? So one of the things I would encourage people to think about is like a life well lived. So if you could look back on your life and you could say, I did what I thought was right at the time that I did it. I lived with integrity, even if it was uncomfortable. I think that is probably a better place to look back from than a life where you said, I played it safe. I just kept my life small, and the most important thing to me was that I didn't experience any discomfort. Like, I don't think that's what most people want. If you ever get the opportunity, you should just Google a woman called Bronnie Ware and the top 5 regrets of the dying. I won't spoil that for you, but just leave you with that. Like, that's because I don't think most people look back and think, well, the most important thing was that I didn't feel uncomfortable. Most people look back and think, I did cool stuff. Like, I lived my life in the way that I wanted to live it. Just to illustrate this, Ravi, what are you most proud of in your life?
Strangely, and this is quite meta, to be honest, this podcast, it's reached a broader audience than I ever thought it would, so I'm really proud of it.
Okay. And that was easy, like a walk in the park for you? Like, no stress?
It still isn't. Never has been, probably never will be.
Right. What are some of the uncomfortable things that you've encountered in the context of doing this?
Imposter syndrome a lot of the time, logistical nightmares, time pressures, trying to balance it with other things that I value in my life as well. A whole host of stuff.
Horrible psychologist from Birmingham asking you personal questions. Right. So, like, if you ask people that question, it's a question I'm very fond of asking. Like, if you were going to die tomorrow, like, what could you say today that you would look back on with great pride? People will always answer in the way that Ravi just answered there, which is they'll tell you something that was hard. They'll tell you something that was difficult. Nobody says like winning the lottery. That's the proudest moment of my life. So, inheriting my nan's house. People don't say that. They talk about things that were difficult. So I think there's value in things that are difficult, and it almost, because going back to my thing about, in your pain you find your values, in your values you find your pain. If it's difficult, it's important. We don't care about the stuff that isn't important. Like, that doesn't distress us. We hurt where we care. And so I think just keep putting your feet down in a valued direction. Like, that's more important than am I feeling better? And I think, that there's probably got enough evidence about value-driven behaviour that if people stick with it, distress does eventually fade into the background. It becomes less sort of intrusive. But often we're not in a business where there's quick results, unfortunately. One of the things I try to impart to trainees really early on is that function is more important than form. I guess what I mean by that is if you had somebody who was running through a forest, right? You saw a guy running through the forest, and the reason he's running through the forest is because he really likes trail running. And then next day you're in the same forest, you see a guy running through the forest. Now he's running through the forest because he's being chased by a bear, right? The form is the same. It's just the guy running through the forest. But like functionally speaking, that behavior is completely different, right? The first guy, he's probably got, joy in his heart. He can do that behavior really flexibly. He can run fast. He can run slow. He can run here, there. He can stop to look at the sunrise. The guy's being chased by a bear. That is a rigid behavior, right? He's running as fast as he can in one direction, which is away from the bear. So functionally speaking, the first guy is sort of making what us ACT folk like to call a towards move, right? He's moving, engaging in behaviour that's got appetitive functions. He's got an appetite for it. He's moving towards things he cares about. The other guy is just running away from something that is going to kill him. It's got a highly aversive functions, and he's doing an away move. He's just moving away from stuff. So function is more important than form. And so the function of a metaphor is more important than the form of it. So if you don't like the particular wording of a certain ACT metaphor, or it's just not going to land well with your client, then just change it. As long as functionally speaking, you get the same kind of point across. To give you an example, so the quicksand metaphor, right? This was there in the original ACT book. So this kind of goes like, if you've got a client with really high anxiety, you might say something like, hey, do you know, like struggling with your anxiety like this is kind of a bit like struggling in quicksand, like rather you be the client. Like,
Go on, yep.
What's the one thing you mustn't do when you fall in quicksand?
They say you shouldn't fight.
Right, you shouldn't fight, because what happens if you fight?
It just drags you down lower and lower and lower.
Right, so it's going to kind of drag you down, pull you under. So struggling with your anxiety is kind of like that, right? The more that you say, don't be anxious, stop being anxious. No, I'm getting anxious. Stop that. The more it's going to kind of drag you down. Like the more anxious you're going to get, and the more it's going to pull you under. So can you kind of see how anxiety and quicksand are sort of similar? So now ACT folks are geeky, right? There's loads of research being done about all sorts of things. And one of the things that's been found is the quicksand metaphor has declined in efficacy over time. And probably the reason is because kids aren't watching Indiana Jones, and they're not watching the sort of cowboy films that I watched when I was a kid. They don't even know what quicksand is, right? So it doesn't work as a metaphor because people don't understand the kind of, there's geeky words about metaphors, like they don't understand the vehicle that you're attaching to the target.
I'm really glad you said that, because I always start that metaphor by actually asking, do you know what quicksand is? And to lend some credence to that ongoing research, the amount of clients who are coming back and saying no clue is definitely on the rise.
Somebody trained you very well. I don't know who that guy was. The task there might be like, how can I get this idea across to somebody in a different way that's going to be more kind of, they're going to be more receptive to. So like, as luck would have it, the Royal National Lifeboat Association put out an advert, a couple of years ago about what to do if you fall in the sea. And it turns out it's exactly the same, right? You shouldn't flap around and struggle. You should just kind of lie there. And it's like you just relax, you lie on top of it, you make contact with the sea with every part of your body, and as hard as that is to do, like that's the thing that's going to keep you alive. And so it's kind of similar with anxiety, right? If you could just experience it, let it be there whilst you turn your attention to trying to survive, you're better off. So I think one of the ways that you can navigate that whole thing about metaphors is to try and find a way of rephrasing it so that it's relevant to a person's life. I mean, just to give another example, there's a classic one that gets used in ACT a lot is the sky and the weather. So it's an old Buddhist phrase, and it goes like, you're the sky, everything else is the weather. And what it's meant to do is to help somebody discriminate between, there's all of this stuff going on inside of me, like raging thoughts and feelings, and the weather keeps changing, but there's a part of me that's bigger than all of that. I'm like the container for that. And if I can kind of notice that the weather keeps changing, my thoughts and feelings keep changing, but I don't change, that notice a part of me doesn't change. And no matter how bad the weather gets, it doesn't damage the sky. And so no matter how bad your thoughts get, they don't damage you. You're still intact and whole and bigger than any of your experiences, etc. I've had clients who would think, yeah, that's a bit flowery, that's a bit airy-fairy. Like I remember working with a builder, right? And I just thought, he's not going to go for that. So we talked about Like, say you move into a house, you move into number 32, and you're a builder. So you might change it. So I'd probably do this really Socratically. Like, have you made changes in your house? And the guy's like, yeah, well, I knocked down a few supporting walls and we opened it out and we put a conservatory on the back. So it's really changed and it's different. And it's still number 32. He could get that, like, a house is sort of more than the sum of its parts. And you could change lots of things inside of the house, but the house is still kind of like, it's different and it's the same. The house is bigger than any of the rooms. I was working with a musician once, and she was like, she said, I've got it. She said, it's like you are the conductor of an orchestra. She said, like, you can't really choose what's written on the page. This was like her idea of, like, your mind just is going to keep saying stuff to you. I don't know about you. I don't choose my negative automatic thoughts, right? They just happen to me.
Yeah.
You can't choose that. But she said, as a conductor, you can decide to sort of emphasize the strings or quieten the horns. It's like all of this stuff is just going on, but there's this person in the orchestra who's kind of can see it all and can make some subtle tweaks to what they pay attention to. And it's like, that's the same idea, right? It's that, like, the sky being like the orchestra and then the individual players being like the weather. So if you can tap into something that's of relevance and interest for the client, like, maybe you can keep the same functions of the metaphor but change the form of it.
Definitely. With the types of therapy that we do, co-production is usually the best tonic in these sorts of situations. But I can also imagine that sometimes it's quite helpful to have almost a repertoire of metaphors to fall back on, just in case that co-production element doesn't work out. And I was just wondering if you knew of any particular materials, books that could perhaps help facilitate some sort of development in that area.
So I am still writing down metaphors every time I hear them, and with the intention of doing something with it one day, but I haven't. Whilst you're waiting for that, the best resource, I think, is something brilliant. The Big Book of ACT Metaphors. The Big Book of ACT Metaphors, it does exactly what it says on the tin. It's just a great big book full of ACT metaphors, and they're all divided up into the sort of 6 different components of the psychological flexibility model. So it's full of, like, mindfulness exercises, metaphors, stories, anecdotes, things that you can use to try and get the idea across. I would say as well, like, if possible, try and do stuff experientially rather than sort of teaching or explaining. I guess a bit like, say, I've done various points with Ravi tonight. I could have just talked about something, but we did it instead of talking about doing it.
Yeah, definitely. I think to also add to that list as well, for perhaps a bit more of a tongue-in-cheek look at some ACT metaphors, there's a book called ACT Made Yorkshire by Dr. Steve Jones. That might perhaps facilitate a bit of a different look at some ACT metaphors. Definitely don't want to stereotype here, but they might come across as perhaps a bit less flowery, if that's the kind of complaint that's coming back to you. Speaking of books, though, Rich, you are a prolific author in the ACT space. Please tell our listeners where they can find some of the books. What are the titles they should look out for? What are the resources you've authored that you would recommend for people who are just starting out with ACT?
Well, thank you for that opportunity to plug stuff. I always get a bit embarrassed at this kind of thing, but I've been involved in writing 2 books, both with Routledge, the publisher, which they're sort of like episodes 1 and 2, really, I suppose. And it's based on my experience of training people who know nothing about ACT to getting them to a point of some competence. So the first one I co-wrote with Joe Oliver, and it's Acceptance and Commitment Therapy, 100 Key Points and Techniques. So that had a second edition out this year, just a few months ago. And that is, I don't know if people have come across the 100 Key Points series, but it's literally that. It's 100 short chapters. Chapters are probably like 500, 600 words each. So it's kind of like, if you think, oh, what was diffusion again? You can open this book and you can read a very short chapter on diffusion. And so it's full of theoretical stuff, practical stuff, relational stuff. Then part 2 is for people who perhaps know a little bit, they've started to use ACT, but are coming up against a bunch of questions about it, like things they're not sure about, is Acceptance and Commitment Therapy, Responses to Frequently Asked Questions, that I co-wrote with my partner in Love and Life, Dawn Johnson. And yeah, we were just asked, what are the 50 questions that you get asked most frequently? And we've written 50 answers.
That's amazing. And you both offer a variety of different ACT trainings as well. What's currently on the roster or the schedule in terms of upcoming trainings, and where can people sign up for that sort of stuff?
The training sort of arm of our company is called activatingyourpractice.com, so you can go there. We are in a bit of a fallow period because Dawn is the current president of UK ACBS, so she's been ploughing all of her energy into arranging this conference at the weekend. Coming back from that, going to have a holiday, and then we're going to get back on. So there's a few on-demand things you can do on there already, but we're a new schedule of trainings yet to be announced for next year. If people are interested, though, I mean, one of the training courses on there is just called the ACT Treasure Trove, which is, it's not a course, it's just tons of free stuff. So one of the things about the ACT community is, like, if you thought something was useful and you had a value of being helpful, why would you put it behind a paywall? So, notwithstanding the fact we all have to make a living, we would give things away free as much as possible. So on that website, you can find ACT protocols, therapy resources, research papers, worksheets, handouts, all that kind of stuff. So there's a bunch of stuff on there, which is, so go on there, download it, distribute it, use as you wish. So the ACT Treasure Trove.
And that's on activatingyourpractice.com. Perfect. And if anyone listening out there has any budding therapists in their life who could do with a Christmas or New Year's gift, it might be worth keeping an eye on the Activating Your Practice website and seeing what offers or training dates arise in the new year if you're looking to gift someone amazing expertise in the new year.
The other thing I do, maybe this is not a decent way to behave, but I want to encourage people to commit podultery.
Go ahead, go on.
I do also do a podcast with my good friend Dr. Ray Owen. So he's another ACBS peer-reviewed ACT trainer. So we have a podcast called Two Old Psychologists Talking About Stuff, and that's very ACT consistent. So we cover a lot of things. So we've done a couple of episodes on like values, and one coming out on acceptance, a couple of recent ones on working with the self. So a whole bunch of things from an ACT perspective, if you're interested in listening to more of that.
Definitely. I mean, if you like to do your learning via podcast, which I'm presuming you do, given that you're listening to this, that is a great shout. And if you sort your podcasts alphabetically as well, there's probably be quite close to ours in the list. Another fantastic resource there. Where else can people find more about you, the work you do, or get in touch with you?
So, well, I'm always often to be found at the University of Birmingham running a high-intensity training course. That takes up a lot of time. I work in private practice, the private practice arm of the company. So we offer supervision and therapy. That's Think Psychology. So you can go to thinkpsychology.co. And if anybody wants to get in touch, I'm more than happy to take inquiries and things. There's a contact form on the website. You can contact me via that.
Amazing. And any other social media presences or anything like that?
I'm a little bit old for all of that. A little bit on Instagram, but not really.
Okay, cool. In that case, probably thinkpsychology.co, probably the best way to reach out to you. Thank you so much for your time today, Rich. It is an absolute pleasure to have you on the podcast. We'd love to have you back on again as well, and wish you the best of luck with everything moving forward.
Thank you very much. Can I say, I meant to say this right at the start, and then you asked me a question straight off, so I got distracted. But I wanted to say what an absolute pleasure it was to be on this podcast. So given that I'm someone who has a value of being helpful and a value around education connected to that, like, it's been an absolute joy to watch you and Shell launch this podcast, which I know is really important to lots of people. And so it's kind of like, I know I'm not your dad, so it's perhaps sort of misplaced of me to feel proud.
Not at all.
I feel incredibly proud that two sort of former trainees have gone and done such a cool thing. And sort of, I suppose it's about extending that being helpful out in different ways. I had a similar experience in Poland recently. Went to a workshop that was run again by a former trainee, and it's like, this is just awesome. Like, I love seeing people grow, develop, spread their wings, and then go on to help so many other people. So, it's an absolute pleasure to be part of this, and I'm very proud of you, whether that's misplaced of me or not.
Thank you very much. I mean, I wouldn't say it's misplaced at all. In many ways, I felt like you were my course father when I was on the high intensity training course. So I think it all fits together pretty I know that we had some quite big dreams when we started. We were talking about round tables of different course leads from across the country and all that big fancy stuff. And I think we've had to do a lot of acceptance along the way that things are perhaps going to be a little bit smaller than we envisioned. I think that we've managed to build something that hopefully people find really helpful, and your comments are very heartily received. So thank you very much for that, and please come back very, very soon.
Yeah, you're very welcome to my comments. They are completely genuine, and yes, I'll be back in a heartbeat.